To announce Selim Corbacioglu. He is Associate Professor and Chair of the Department of Hematology and Oncology and Stem Cell Transplantation at the Children's Hospital in Regensburg. He will speak about the prevention of VOD and graft versus host disease, and I guess he will present the EBMT study just appeared in Lancet, or yes. Almost, or please.
Thank you for the kind introduction, and thank you for being here on a Sunday morning. It's going to be a quick and easy home run for me after all these nice presentations to sum up what we learned about VOD, defibrotide, and GvHD. Now, first question, I think this is already answered. Is VOD a concern in stem cell transplantation in 2012? We have all kinds of tools. We have fantastic choices for our donor selection. We can vary our conditioning regimens, but still, VOD remains a concern, as it was shown by Jason Koppel's really fantastic meta-analysis, that VOD is around. The incidence is either 9.6%, I go with this one, or if you look at the Seattle criteria, it's 17.3%, and also this difference is really important to notice, that VOD is not going away, despite our improvements. In children, the story is slightly different. There are two fairly large single-center analyses on the incidence of veno-occlusive disease, one by Barker from California and the other one by Simone Cesaro from Italy, 18%, 10 to 30%. These data were corroborated by the prevention trial that I'm going to show you in a minute, with an overall incidence of 22%, but the incidence in the very small patients, up to 23 months of age, goes up to 29% overall. The reason for this is, first of all, the risk factors that we know from all patients. So stem cell transplantation for patients beyond the second relapse, prior myeloablative stem cell transplantation, so toxicity, busulfan, especially when combined with melphalan and cyclophosphamide, as we have heard from Enrique, hepatic diseases, as we know, severe hemocirrhosis, hepatitis, fibrosis, but also simple transaminitis prior to stem cell transplantation increases your risk without any evidence for reason. Myelotarg was already said by Dietger, and abdominal radiation that we don't use as much. But wait a second. But there are additional risk factors in children, and that is the point with a 30% incidence in kids. There are certain diseases like osteopetrosis, like HLH, macrophage activating syndromes, sloppily summarized here, Ruscelli syndrome and others, and also neuroblastoma, who have a persistently high incidence during transplantation and during treatment. Another ugly kid on the block is Wallmann's disease, lysosomal acid lipase deficiency. The incidence is almost 100% and almost 100% fatal. So we will have genetic diseases associated with veno-occlusive disease that we cannot really manipulate by changing our conditioning regimen or our donor selection or our drugs we use, because we think that there are factors that produce and generate veno-occlusive disease independent of those factors that we can adapt. Another important aspect already mentioned, severe veno-occlusive disease. And one of the persons in the audience asked about risk factors, or how can we identify severe VOD? It's retrospectively. No, it's prospective. Yeah? It's prospective. Multi-organ failure, encephalopathy, renal impairment, pulmonary impairment, VOD with multi-organ failure, your mortality goes up beyond 80%. No approved treatment, current standard of care, best supportive care, maybe defibrotide, as we have seen before. Mortality, 84%. But that's not the whole story. When you look again at the paper by Barker et al. Published in 2003, he looked at the mortality in children with veno-occlusive disease. We're not talking about severe VOD, we're talking about mild, moderate, and severe VOD. Those patients, the mortality quadrupled from 9.5% to 38.5%, no matter if it was mild, moderate, or severe. Again, here, our trial corroborated those data. 285 patients, 57 patients, 6% versus 24.6% mortality by day 100 of all causes. So it's a relevant disease by incidence and by outcome. Now, is VOD still a concern in 2012? I think yes. Yeah. The incidence remains high despite scientific progress. Significantly higher incidences in children, often due to genetic diseases that we transplant. The VOD-related mortality is high, irrespective of severity. And patients with no obvious risk factors can still suffer from severe VOD. And I think we all have these experiences that we are completely flabbergasted and surprised that a patient with no risk factors whatsoever stumbles over very severe veno-occlusive disease into the intensive care unit. Now, defibrotide for the treatment, this is easy to be done. These are a summary of the most recent publications on this. And really here, the credit goes to Paul Richards' publication in 1998, which was really the pivotal kickoff to show that defibrotide might be beneficial for the treatment of veno-occlusive disease. Time counts. We have seen this before as well. I just summarized the pediatric data here as well. We published a trial for the treatment of veno-occlusive disease in 45 children in 2003. And this was basically the kickoff for the prevention trial, where we saw that when patients were treated with defibrotide, within 24 hours, up to 48 hours of diagnosis with defibrotide, the complete response rate overall was significantly better, in particular in patients with severe VOD, 28% versus 87% CR. And in the multivariate analysis, early intervention remained the only significant factor for a complete response. These data were corroborated by Enrique, as we have seen before, and also a summary on the outcomes of the compassionate use trials. Early treatment versus late treatment, 22% versus 45%. Again, in this subset, 3 days versus less than 3 days, 49% versus 60%, both highly significant. Time counts, so you better start early. What's the role of Baltimore and Seattle in this setting? Just to give you an overview, Baltimore and Seattle criteria. We have the obligatory hyperbilirubinemia in the Baltimore criteria, additional 2 factors. Not so with Seattle. So hyperbilirubinemia is one of those 2, in addition to hepatomegaly, painful usually, weight gain, 5%, modified Seattle also 5%, ascites, and onset before day 30 or before day 20, respectively. Now, when we looked at the pediatric trial, elevated bilirubin, no elevated bilirubin, the incidence, basically Baltimore and Seattle, the incidence at day 30 is 13% versus 20%. Incidence of multi-organ failure by day 100, 60% versus 32%. Significant survival, 69% versus 86%. Corroborating again the analysis, meta-analysis by Jason Koppel, 17.3 versus 9.6%. So that there's a difference in the incidence of VOD between Baltimore and Seattle. But in the pediatric trial, 32% developed VOD without or late onset hyperbilirubinemia. So if you wait for hyperbilirubinemia to occur, it might never show up, or it might show up in the late phase associated with multi-organ failure. The day limit, 28% of VOD occurred after day 21, and 10% of the patients developed veno-occlusive disease even after day 10. So just per definition, these patients would have not been called VOD. Age counts. This is a good message. So the incidence is higher in children, but overall, Baltimore and Seattle, children fare better than adults when they're treated with defibrotide. This is the pivotal trial where we compared, or Richardson's work compared a historical control group with intervention of defibrotide, and in particular the pediatric population benefits best from intervention of defibrotide. 7% versus 36.4% when being treated with defibrotide. Now, overall, there's a high incidence in children, early versus late intervention, so you have to start early. Benign adverse event profile, as we have seen from the publications and the presentations before. There are poor diagnostic tools, as we know, so we only have the clinical criteria. There are no really good early biological or imaging markers that can define and identify the disease early on. And all this basically leads to the point that we should probably try to use defibrotide for prevention of veno-occlusive disease rather than treatment. And these were the 4 points that led many of us to look at defibrotide for prevention. And eventually it led to the VOD defibrotide prevention trial, which was a prospective phase 3 multi-center randomized trial conducted by the EBMT and Gentium. The objectives: incidence of VOD by day 30 in children at high risk for VOD. Those were the patients that we have identified earlier. Secondary objectives: morbidity, mortality, so VOD-associated multi-organ failure and survival through day 100. Incidence and severity of graft versus host disease. The trial design is known to most of you. Eligible pediatric patients were randomized and stratified by center and incidence of osteopetrosis. The prophylaxis arm started at 25 milligram per kilogram per day on the first day of conditioning, compared to the control arm where no prophylaxis was used, although ursodiol and heparin was allowed. Patients who then developed veno-occlusive disease continued with a proven efficacious dose of 25 milligram per kilogram. But let me draw your attention to this point, that the control arm, after fulfilling Seattle criteria, was able to start treatment with defibrotide as well. So not waiting for Baltimore or anything, waiting for Seattle and start preemptively with defibrotide, same dose, 25 milligram per kilogram per day. Results: the sample size, 360 patients collected over 3 years from 2006 to 2009, 28 participating pediatric transplant centers from Europe and Israel. The quality of the trial was very high. The study was fully GCP conform, monitored by qualified CROs, and we have 100% source data verification. So every single chart was checked and over, checked physically again, to the point that some of us were really, they had it. Good. Primary endpoint: incidence of veno-occlusive disease by day 30, the intent to treat analysis, competing risk 12% versus 20% in the control arm with a p-value of 0.488, so a reduction of 40% in the protocol analysis, competing risk 11% versus 20% with a p-value of 0.0225. And when we just look at the subset of the Baltimore criteria patients, 7% versus 13%. So it's consistent with this narrow subset of patients that present rather with severe disease with hyperbilirubinemia. Secondary endpoint: multiple organ failure. So we use a scoring system implementing mortality and morbidity. And here again, within the score with the Wilcoxon test, the p-value was highly significant that preemptive treatment failed compared to prevention and reduced morbidity and mortality. And in particular, renal failure, 6% versus 1% per se, highly significant with a p-value of 0.017. An important question here: VOD-associated mortality at day 100 was lower in the defibrotide arm compared to the control arm, 2 versus 6%. Of course not significant because the trial was not powered. The overall mortality was similar between both arms. This, of course, can also be explained by the design of the trial that at that point was not able to be conducted ethically, not to treat patients with defibrotide on the control arm. So we have this crossover design for those patients preemptively that blurred the overall mortality view. Of 28 patients from both treatment arms with severe veno-occlusive disease, 68% survived to day 100, and 9, that's 32%, succumbed to their disease. Of 26 patients from both treatment arms with mild to moderate veno-occlusive disease, 88% survived to day 100 and 3 died. These 3 patients were in the control arm. That means 3 out of 15 patients, 20%, who did not receive VOD prophylaxis died by day 100. So it's not a mortality that is associated with severe disease. It's a mortality that is associated with the incidence of VOD per se. Another important question: adverse events. They were well balanced between the defibrotide arm and the control arm. Mind you, we used a prophylactic treatment for children in stem cell transplantation. That is adverse events before and after veno-occlusive disease. So to summarize this part here, VOD incidence in children is higher than in adults, as we know. Prophylactic defibrotide compared to even preemptive treatment, according to Seattle, reduced significantly the incidence of VOD by 40%, VOD-related morbidity and mortality, and acute GvHD, both in incidence and severity. Now, what happened? We looked at the incidence of graft versus host disease in those patients for known reasons. Acute GvHD grade 1 through 4 was significantly reduced overall from 65 to 47%. Chronic GvHD was not affected, talking about acute GvHD. And in the subset analysis of grade 2 to 4, again, highly significantly reduced from 37 to 22%. These data were corroborated by the utilization of corticosteroids. So, concomitant medications were balanced between treatment arms with the exception of the category of corticosteroids. Corticosteroids were used in 37% of patients with defibrotide prophylaxis versus 48% in patients in the control arm, p-value 0.363. Cortisone or corticosteroids were prescribed predominantly for acute GvHD, 76 versus 22%, and were used significantly less in patients receiving defibrotide. So, reflecting the lower incidence of acute GvHD in the defibrotide arm. How do we get now VOD and defibrotide together? Now we know, and we heard that from Ernst and the other speakers, that defibrotide reduces the conditioning-mediated activation and apoptosis of endothelial cells. Defibrotide protects endothelium from pro-inflammatory stimuli. Defibrotide restores the antithrombotic phenotype by increasing the fibrinolytic activity. And it does that by manipulating all these factors that are involved somehow in VOD, GvHD, and other post-transplant complications, therefore protecting and stabilizing the endothelium. Now our theory is, as a model for the protective effect of defibrotide, that the endothelium stays at the center of a complexity of post-transplant complications. A gatekeeper, the primary partner of an activated immune system, of an activated system that is related to the toxicity with transplantation. Now, we have several LOXes that affected this endothelium during transplantation, like myelotard, our immunosuppression, inflammation, conditioning regimens, toxicities, and irradiation. This leads to a kind of angry endothelium, secreting and expressing surface markers and factors that are associated with an endothelial activation, pro-inflammatory status, and upregulation of adhesion molecules. The consequence could be transplant-related complications as we know them all, like VOD, like capillary leak syndrome, Grafton syndrome, acute graft versus host disease, transplant-associated microangiopathy, diffuse alveolar hemorrhage, idiopathic pneumonia syndrome, and probably many others. Now, defibrotide could work as a factor that shields the gatekeeper of stem cell transplantation, the endothelium, as a potential tranquilizer of systemic transplant-related complications. And, this is a very provocative question, it could separate graft versus host disease from graft versus leukemia, not manipulating the immune modulatory side, but the primary target side. Thank you very much.
Thank you, Selim. Questions?
Questions?
Hi, I'm Satin from Sickkids Toronto. 2 questions. Was there a difference in autologous versus allogeneic when we use defibrotide for the prophylaxis?
No.
There was
No difference.
So the second question is, when we look at the prophylaxis versus no prophylaxis, there is a clear-cut difference. But when we look at the day 100 outcome in the mortality, it's almost same. So that means then when we put the patient onto defibrotide, and even then if VOD happens, those are the patients who are not responding, or the mortality ultimately comes to the same. So maybe we need to increase the dose, or what's going on? I mean, how come is it coming to the same?
When you look at the patients that suffered from veno-occlusive disease, there's a difference. But the difference is not statistically significant because the study was not powered for mortality. So that's the VOD subset. In the overall subset, the result is also blurred because we use defibrotide for treatment. So there, you know, the overall mortality is also biased by the fact that both groups received defibrotide. And of course, patients have additional complications. The fact that they leave their units and have to go to a probably infectious and more complicated environment like an intensive care unit affects their outcome as well. So it's not easy to read out from those data.
Further questions? Yes, go ahead.
Lady Dublin, was there any difference in the incidence of relapse in the patients who were treated with defibrotide versus not?
We looked at, I didn't show it here for the shortness of time, but there's no difference in relapse.
And do you or any of the other speakers have any data on the use of defibrotide in thrombotic microangiopathy post-transplant?
TAM was a secondary endpoint, but due to the very low incidence in this setting, we didn't observe any differences in outcome.